So we're discussing how to manage ventricular tachycardia. So the patient develops ventricular tachycardia. How are you going to identify ventricular tachycardia? If ECG shows broad tachycardia, then it is ventricular tachycardia. And a patient with ventricular tachycardia is clinically stable, then we'll manage this tachycardia or ventricular tachycardia by giving him a drug, antiarrhythmic drug, that is amiodarone. And if the ECG is showing ventricular tachycardia and the patient is hemodynamically unstable, what does hemodynamically unstable mean? Means if the patient blood pressure is less than systolic blood pressure is less than 90 and he is having ventricular tachycardia, and then remember the rule that any arrhythmia in an clinically or hemodynamically unstable is managed by cardioversion. So ventricular tachycardia plus hemodynamically stable patient, amiodarone, ventricular tachycardia plus hemodynamically unstable patient, DC cardioversion. And if the patient is unconscious, collapsed, or not breathing, plus no pulse, then it is most likely ventricular fibrillation. And the only option that we have is to defibrillate the patient as soon as possible, because if we do not defibrillate the patient, then the patient will goes into cardiac arrest. So if the pulse is present, then it is mostly ventricular tachycardia. And if the pulse is not present, then it is most likely ventricular fibrillation. And we can confirm this by doing an ECG. If ECG shows broad complexes, then it is ventricular tachycardia. And if ECG waves, then it is ventricular fibrillation. Remember that ventricular fibrillation is the most important shockable arrhythmia, and hypokalemia is the most important cause of ventricular tachycardia clinically. So a patient with electrolyte disturbances such as hypokalemia can also develop ventricular tachycardia, or the patient can also develop ventricular tachycardia after MI. So if a patient presents to you with ventricular tachycardia with no history of MI, then you need to check his electrolytes to rule out hypokalemia. So again, a summary of management of ventricular tachycardia and ventricular fibrillation. How the patient, what will be the signs and symptoms of the patient in ventricular tachycardia? The patient will complain of lightheadedness, palpitations, and chest pain. And ECG will show broad complexes. If the patient is hemodynamically stable, then we will give amiodarone. If he is unstable, his systolic blood pressure is less than 90, and there is loss of consciousness, then immediate cardioversion. And if the patient suddenly collapses after MI and he stop breathing and he is unconscious and there is no pulse, then it is most likely ventricular fibrillation and immediate defibrillation will be the management of such patients. So this was all about the one of the immediate complication of the MI, that was tachyarrhythmia and their management and their diagnosis. Is it clear to everyone? Is there any question up to this point? Okay, the second immediate complication of MI is acute decompensated heart failure. What will happen if there is decompensated heart failure, or heart fails to pump the blood in the aorta or in the pulmonary circulation? Heart failure can manifest in two forms. One is pulmonary edema, and the other one is ascites or peripheral edema. So left-sided heart failure, if there is left-sided heart failure, then the blood will start pooling in the left ventricle, left atrium, and there will be backflow of blood in the pulmonary vasculatures or pulmonary veins, which will lead to increased hydrostatic pressure in the pulmonary veins and pulmonary capillaries, and the blood will come out of the pulmonary blood vessels, and which will result in pulmonary edema. So left-sided heart failure can lead to pulmonary edema, and right-sided heart failure can lead to pooling of blood in the peripheral veins or in the abdominal veins, which will result in ascites or lower limb edema. If both of the features are present, such as pulmonary edema and peripheral edema, then we will say it's a biventricular failure or congestive heart failure. What will be the features of pulmonary edema? The features of pulmonary edema include patient will desaturate, he will develop shortness of breath and orthopnea. Shortness of breath will be worse on lying down, and on examination or on auscultation, there will be crepitations or crackle at the bases of lungs. So the second immediate complication of the MI is decompensated heart failure, which can manifest as pulmonary edema. Now, the features of pulmonary edema is shortness of breath and orthopnea, and on examination, there will be crackles or crepitations. Now, how we can diagnose, which investigation can be done to diagnose pulmonary edema? The most important initial investigation for the diagnosis of pulmonary edema is chest X-ray. What will be the features of chest X-ray in patient with pulmonary edema? This is a chest X-ray of a patient with pulmonary edema. You can see these thin linear opacities. These thin linear opacities are called curly lines, curly B lines, curly C lines, or curly A lines. Curly A lines if they are present at the apex, curly B lines if they are present at the base, and curly C line if they are present in the middle lobes, or you can simply call them curly lines. So the most important diagnostic investigation in a patient with features of pulmonary edema is X-ray. X-ray in a patient of pulmonary edema will show curly lines or bat wing appearance of hilar vessels. What is bat wing appearance? The appearance of the X-ray or the pulmonary vessels is just like the wings of a bat. See, this is a wing and this is also a wing, and on this side as well. So on X-ray, two type of features can be present: curly lines and bat wing appearance of hilar vessels. This is how we are going to diagnose pulmonary edema on chest X-ray. So if they ask you about the investigation to diagnose pulmonary edema, then it will be X-ray. And if they ask you about the investigation to determine the cause of pulmonary edema, then echocardiogram will be the answer. Because on echocardiogram, we can see what has led to heart failure, such as after MI, acute mitral regurgitation or ventricular aneurysms or ventricular wall rupture, they all can lead to heart failure. And that we can only see on echocardiogram. So if you want to identify the cause of pulmonary edema, then the investigation of choice will be echocardiogram. And if you want to diagnose pulmonary edema, then the investigation of choice will be chest X-ray. So the most appropriate investigation, chest X-ray, investigation needed to identify the underlying cause, echocardiogram. Now, some points about the management of pulmonary edema. Management is always MI. In MI, the initial management was morphine, oxygen, nitrates, and the fourth one was aspirin. But here, aspirin will be replaced by furosemide. So initially, we'll sit the patient in a pop-up position and give oxygen. We'll aim for oxygen saturation of 95 or more than 95. In generalized population, and an oxygen saturation of 90% or more than 90% in COPD patients. So the first step is to set the patient in proper position and give him oxygen. The second step is sublingual glyceryl trinitrate. Glyceryl trinitrate will lead to vasodilation and it will decrease afterload. So basically it can increase cardiac output. Then we can give furosemide by the name Lasix, 40 milligram IV, and morphine or diamorphine to relieve pain, anxiety, and distress that is associated with shortness of breath or dyspnea. So again, a short summary of the management of acute pulmonary edema. Acute pulmonary edema is managed by setting the patient in proper position, oxygen, glyceryl trinitrate, and furosemide, and morphine and diamorphine. So this was all about acute management of pulmonary edema. Now, some points for the long-term management of chronic heart failure. Chronic heart failure, the long-term management of chronic heart failure includes the same drugs such as loop diuretics if the patient is in volume overload. How you are going to know that if the patient is in a volume overload or not? If there are features of pulmonary edema and if there is lower limb edema, then you will prescribe loop diuretics such as furosemide. And the other long-term medication for chronic heart failure is ACE inhibitors or beta blockers. We'll start with one drug, either ACE inhibitor or beta blocker, and if there is no improvement with single drug, then we will add the other one. For example, in a patient with diabetes and if he is having chronic heart failure, then we will start with ACE inhibitors. And if the patient's symptom does not improve with only one drug, then we will add beta blocker. And if the symptoms still persist, then we can add a third drug, which is spironolactone and aldosterone antagonist. Remember that in heart failure, there are two compensatory mechanisms that are activated in the body. One is sympathetic system. In case of chronic heart failure, sympathetic system is activated, which leads to increased heart rate, force of contraction of heart to compensate for the heart failure. And the second one, and the second system that is activated is renin-angiotensin aldosterone. Because of decreased blood flow to the kidneys, renin is excreted by the kidney cells, which lead to the excretion of or conversion of angiotensin 1 to angiotensin 2, and then angiotensin release stimulate the release of aldosterone. So these two compensatory mechanisms are basically causing the damage in chronic heart failure. So that's why we give a drug that will block these two systems, beta blockers to decrease the effect of sympathetic system activation, and ACE inhibitors to decrease the effect of renin, aldosterone, angiotensin system. We'll start with one drug and add the second if the symptoms persist. And even after adding two drugs, the symptoms still persist, then we'll use an aldosterone antagonist such as spironolactone. So the long-term medication or the long-term management of chronic heart failure include three drugs: ACE inhibitor, beta blocker, and aldosterone antagonist. We can add all three of them in a stepwise manner. And if the patient cannot tolerate ACE inhibitors, such as captopril, enalapril, lisinopril, if they develop dry cough, then we can replace ACE inhibitors with ARBs, angiotensin receptor blockers, such as valsartan, telmisartan, etc. And
Could you repeat that again? The last part?
yes, if someone cannot tolerate ACE inhibitors, such as the most common side effect of ACE inhibitor is dry cough. So if someone develops dry cough with ACE inhibitors, then you can change. Then in place of ACE inhibitors, you can prescribe ARBs, angiotensin receptor blockers, such as valsartan or telmisartan.
Thank you.
So a short summary of management of acute heart failure and chronic heart failure. The drugs which can be used in the management of acute heart failure include furosemide and oxygen and morphine and glyceryl trinitrates or nitrite. And the long-term management of heart failure is ACE inhibitor, beta blocker, and in third step, aldosterone antagonist. And if the patient is having signs and symptoms of volume overload, such as pulmonary edema or lower limb edema, then furosemide can also be prescribed with all the other medications. So this was all about the management of heart failure, acute and chronic both. So we are done with the second immediate complication of MI. First one was ventricular tachycardias, ventricular tachyarrhythmias, and the second one is heart failure. Now we know how to manage ventricular tachyarrhythmias and heart failure, acute heart failure, and chronic heart failure. Now remember that if a patient with the heart failure presents to you and he has diabetes, then the first drug that you will start is ACE inhibitor and not beta blocker. In other patients, you can start with beta blocker or ACE inhibitor, but in diabetes, ACE inhibitor will be the first choice. And if the patient presents to you with heart failure as well as he is having atrial fibrillation, then digoxin will be used in the management of heart failure in such kind of patients.
Sorry, please repeat the last point.
Yes.
Patient with heart failure plus diabetes, then you will take a start from ACE inhibitor and add the other drugs such as beta blockers and spironolactone or aldosterone antagonist in a stepwise manner. Now, if a patient with atrial fibrillation develop heart failure, then the drug that you are going to use for the management of this atrial fibrillation is digoxin, because digoxin will correct his atrial fibrillation as well as it will manage or improve his heart failure as well. Is it clear, everyone, up to this point? Is there any question anyone want to ask?
You said something about like if both are present, like pulmonary edema and peripheral edema, then it is uh, you gave a different.
Biventricular failure,
Okay.
biventricular failure or congestive heart failure, the management will be the same. For
Right.
fluid overload, for lower edema or peripheral edema or pulmonary edema, the drug
Mhm.
that is used is loop diuretic or furosemide.
Right. Thank you.
Now, a patient with chronic heart failure develop gout. Now, remember that loop diuretics and thiazide-like diuretics, there is a side effect of these drugs is that they can cause hyperuricemia. They lead to decreased excretion of uric acid from the body. Diuretics such as loop diuretic and thiazide diuretic, they cause hyperuricemia. So if the patient with heart failure, if in the Plab 1 exam they ask that a patient with chronic heart failure has developed gout, and they ask you about the cause of their gout or their symptom, then your answer would be diuretics. So a patient with chronic heart failure, if he develop gout, then the cause of his symptoms will be diuretics. Now there's another scenario. Remember that NSAIDs decrease GFR, and a decreased GFR lead to activation of renin-angiotensin system. So use of NSAIDs can lead to worsening of sign and symptoms of chronic heart failure. Because in chronic heart failure, renin angiotensin aldosterone system is already activated, and it's causing the problems. It is causing fluid overload. So if you prescribe a patient of heart failure NSAIDs, then it can lead to worsening of his symptoms, of his heart failure symptoms, which are shortness of breath and of orthopnea. So if a patient who is having chronic heart failure and he developed gout and you prescribed him NSAIDs, and a few days later he present to you with worsening of his symptoms, and they ask you about the reason of his symptoms, worsening of his SOB, then the cause is most likely NSAIDs. So in other words, NSAIDs are contraindicated in patient of chronic heart disease or chronic heart failure. So there are two scenarios which can be asked in Plab 1 exam. One is a patient with chronic heart failure develop gout, then the cause will be diuretics. And if the patient with chronic heart failure has developed gout and his shortness of breath and orthopnea gets worse, then the cause will be NSAIDs that was prescribed to treat his gout.
If the patient has a gout and they develop heart failure, so which diuretic you will give them?
Which diuretic or painkiller?
No. If for example, if a patient is already suffering from gout and he develop heart failure, I mean the other way. So obviously you have to give some diuretics. So which would be the option in that case?
We can give ACE inhibitors, or
So we'll not give diuretics to gout patient.
we can give diuretics in emergency situation or
Okay.
on short-term basis.
Right.
Because we'll weigh the advantages and disadvantages of use of diuretic. If the patient symptoms or if the patient is in severe fluid overload, then we do not have any other option but to give him loop diuretic.
Right. Okay.
But for long-term basis, we can give ACE inhibitors or ARBs or uh, aldosterone antagonists such as spironolactone, or we can uh, give beta blockers as well.
Okay. Thank you.
NSAID can cause sodium retention and can lead to fluid overload, and they can also cause vasoconstriction because they decrease the synthesis of prostaglandins. So that's why NSAIDs are contraindicated in heart failure and ischemic heart disease and in chronic kidney disease as well, because they leads to a decrease in the GFR. So that's why these are the three diseases in which NSAIDs are contraindicated: ischemic heart disease, uh, uh, heart failure, and chronic kidney disease. So one of the side effects of diuretic, loop diuretic and diuretic is hyperuricemia. The other important side effect of these two diuretic is hypokalemia, because they lead to excretion of potassium from the body. So that's why they can cause hypokalemia. While on the other hand, ACE inhibitors and spironolactone, the drugs that blocks the action of aldosterone, remember that the function of aldosterone is to retain sodium and to excrete potassium from the body. The function of aldosterone is to reabsorb sodium and excrete potassium. So any drug that blocks the action of aldosterone, such as spironolactone or ACE inhibitors, because both of them block the action of aldosterone. So whenever the function or action of aldosterone is blocked, sodium will be excreted from the body. It will be not retained in the body, and potassium excretion from the body will be decreased, and potassium will be retained in the body. So ACE inhibitors and spironolactone causes hyperkalemia, loop diuretic and thiazide diuretic causes hypokalemia. These side effects are important to remember. So this was all about the immediate complications of MI that can occur within 24 hours after an MI, and those included tachyarrhythmias plus heart failures. Now, some more complications of MI that can occur after 24 hours up to 3 days. So after 24 hours, the most important complication that can be developed after MI is pericarditis or acute pericarditis. In MI, necrosis or death of myocardial cells occur. To clear these necrotic tissues or dead tissues, a body starts the inflammatory response, which can be exaggerated, which will result in pericarditis or acute pericarditis. So acute pericarditis in a patient of MI can occur within 2 to 3 days or after 24 hours. What will be the features of pericarditis? The sign and symptoms or the diagnostic sign and symptom for pericarditis is that the patient pain is worse on lying flat and during inspiration. So if a patient with a history of MI or the patient present to you 2 days after MI and he complains of central chest pain or pleuritic chest pain that is worse on inspiration and on lying flat, then you will think of pericarditis. The patient can also have fever, and on auscultation, you can hear a pericardial rub. There are two ways by which you can confirm your diagnosis. Remember that pericarditis can lead to accumulation of fluid in the pericardial cavity, which is called pericardial effusion. So, if a patient presents to you with these features 2 days or 3 days after MI, then you can confirm the diagnosis by performing a chest X-ray. A chest X-ray will show enlarged globular heart because of accumulation of fluid in the pericardial cavity. And you can also confirm it by performing an ECG. Remember that widespread saddle-shaped ST elevation with upward concavity if there are widespread ST elevation or saddle-shaped ST elevation with upward concavity and PR depression, then it is most likely pericarditis. So the sign and symptoms for pericarditis that will point in favor of pericarditis is chest pain that is worst on inspiration and or lying flat, and on X-ray there will be enlarged globular heart, and on ECG there will be widespread ST elevation. elevation with upward concavity plus PR depression. Then your diagnosis will be pericarditis or acute pericarditis. As pericarditis is an inflammatory condition, so the management of pericarditis is full dose of NSAID for 1 to 2 weeks. What is a full dose of NSAID for the management of pericarditis? The dose of aspirin should be 2 to 4 gram per day, and ibuprofen 1800 milligram per day, indomethacin 75 to 150 milligram per day. And they should be given for at least 7 to 14 days. So pericarditis can occur as a complication of MI after 24 hours. Now, if the same patient present to you after 4 to 6 weeks or after 2 to 6 weeks with features of pericarditis such as chest pain that is worse on inspiration and on lying down, and ECG show widespread ST elevation with upward concavity and PR depression, but the patient present to you after 2 to 6 weeks, then it will be known as Dressler syndrome. Dressler syndrome is basically an autoimmune reaction, against antigenic proteins that are formed as the myocardium recover after MI. So if it occurs within 2 to 3 days, if pericarditis occur within 2 to 3 days, then it is most likely due to inflammation of the pericarditis or pericardium. Then it will be called acute pericarditis. And if it occurs 2 to 6 weeks after MI, then it is Dressler syndrome, because the mechanism of Dressler syndrome is different from pericarditis. It is pericarditis, but the underlying mechanism is different. What is the underlying mechanism of Dressler syndrome? The underlying mechanism of Dressler syndrome is that as the myocardium recovers, new antigens are formed against which an autoimmune reaction can occur, which can lead to pericarditis, and the presenting features or sign and symptoms will be same. X-ray findings will be same, and ECG findings will be same in both acute pericarditis and Dressler syndrome. Even the management, a full dose of NSAID are used in both conditions. Only the underlying mechanism is different for the development of pericarditis in Dressler syndrome and in simple pericarditis. Dressler syndrome is basically an autoimmune reaction which can only occur 2 to 6 weeks after MI, because this is the